So what guideline to measure, to follow? There are a lot of guidelines, as you must be aware, for diagnosing diabetes. But I think the IDPS guidelines, which are more commonly followed, why we follow them is because they're the only guidelines which were based on HAPO study, which was basically event-driven. Like they had actually seen the fetal and neonatal outcomes, large for gestational age baby, COD-C peptide, and so neonatal and maternal outcomes were looked at, and then they derived cutoffs, after which they said that if it is beyond this, then the risk of these complications are high. So that is why we prefer these. So IDPSG guidelines again have two things. One is detection of overt diabetes. That should be done at the first antenatal visit with a fasting plasma glucose, RBS or HbA1c. We mainly take the type 2 diabetes cutoffs, that is a fasting more than 125, HbA1c more than 6.5. If they are meeting these cutoffs, then they have had diabetes earlier, which was just picked up right now, and we treat them. If it is below 92, the fasting, we have to rescreen them at 24 to 28 weeks for GDM. Now, if the fasting sugar is between 92 to 125, there is this new entity now that is emerging as early GDM. Early GDM, the consequences are that some studies have shown that, that it is associated with adverse perinatal outcomes. Treating them might have some benefit, but treating them aggressively might lead to more SGA babies later on as well. The second thing is screening for gestational diabetes, which should be done at 24 to 28 weeks. We do 75 gram to 2 hour OGTT, and any one value which is abnormal, that is fasting more than 92, 1 hour 180 and 2 hours 153, we take them as GDM. So pre-pregnancy counseling, any lady who wants to plan pregnancy once she comes to you has to be educated about the importance of glycemic control, about the HbA1c being 6.5 and below, and the better outcomes that happen because of that, and the complications that can happen if she doesn't control the diabetes and maintain euglycemia. How do we monitor such patients in pregnancy? We most commonly do finger stick. How frequently should we do? Should be individualized. If someone is a pre-gestational diabetes requiring high doses of insulin or OADs earlier, probably daily initially till we have very good values, and then we can de-escalate the monitoring. If someone who's monitoring, who is doing well just with medical nutrition therapy, we might check just twice in a week. HbA1c can be done mainly for prognostication, to know the risk. Below 6.5 in the first trimester, below 6 in the second and third is associated with lower adverse outcomes to the baby. So these are the cutoffs that you all are aware of. Fasting should be below 95. If we are targeting 1 hour postprandial, it should be below 140, 2 hours postprandial below 120. What we usually don't talk about is the lower limits. Again, a lot of studies have shown that if the sugar is below these lower limits, that is, if the fasting is below 70, 1 hour below 110, or 2 hour value below 100, then there can again be more risk of IUGR. So not just the upper limits, probably the lower limits also should be mentioned. Medical nutrition therapy mainly consists of some diet modifications that we tell them, decreasing the carbohydrate, mainly comprising of 3 major meals, 2 snacks, and a physical activity of around 20 to 30 minutes after each meal. Now, if the patient fails medical nutrition therapy, we have 2 options. We can either shift over directly to insulin, or we might consider metformin. Insulin, the best thing is basal bolus. We give a 24-hour acting insulin, and then we give boluses pre-meals. Metformin in pregnancy is a very controversial topic, even amongst endocrinologists. A lot of studies have shown that metformin is very safe in pregnancy. Definitely there is no teratogenicity. Why it is controversial is that there are some evidences that say that it might be modifying the epigenetics in the mother. So the cross of glucose and amino acids across the placenta might be different, and epigenetic changes related to energy metabolism in the baby. So there was a trial called MIG trial, which followed patients who took metformin, GDM patients who took metformin, and their offsprings were studied at 7 to 8 years. And they found that these children whose mothers were given metformin in pregnancy had, they were heavier, they had higher BMI. Why, they say, is because we know that metformin might cause low birth weight babies because of that transplacental decrease in glucose and amino acid. So if the baby is low birth weight, they can have a rebound growth in the first year, and that rebound growth per se later on leads to higher BMI in precocious puberty at 7 to 8 years. So that might be a concern there. ACOG NICE guidelines do recommend metformin after a lifestyle modification. ADA, it endorses insulin. It says that is the better thing. But we need to know when not to give metformin. I personally give metformin to most of the patients because glycemic control is achieved beautifully with metformin, especially pre-gestational diabetes who have required high doses of insulin, who were on very high doses of OADs. Just with insulin gets very difficult to control their sugars. When we add metformin, the results are really good. So when we talk about risk benefit, when we reduce the sugar levels, definitely the benefits are also high. When not to give, we know that it can cause low birth weight. So if someone is IUGR, definitely no. So if one of your patients does develop IUGR, I think that is something that you can convey to the endocrinologist that metformin should be stopped. Preeclampsia and hypertension, we need to be very, very cautious because again, they can cause IUGR. CGM in pregnancy, what we say is finger stick is like a photograph, CGM is like a videograph. It gives us more data. There is a patch here which checks the sugar every 5 minutes. So we have a lot of data. When we have more data, we can control the sugar better. The patient is involved. She knows what to eat, what is spiking, what is controlling the sugar. The recommendation right now is only for type 1 diabetes in pregnancy because there was a trial which showed reduction in LGA infants and other outcomes. It is not recommended right now in GDM and type 2 diabetes because data is insufficient. But in addition to finger stick, we can definitely do this. Of course, we monitor fetal growth, anomalies in the early pregnancy, and then later on fetal growth is monitored. During labor, we stop the typical subcutaneous insulin and metformin if we were using. We target a sugar between 72 to 126. We might require insulin infusion for that. Postpartum, most of the GDM patients, most of them become euglycemic. 5 to 10%, it might persist. We stop giving whatever we were giving for GDM patients, and we check the lab value of fasting and after food in such patients. The pre-gestational diabetes patients, we need to be, definitely the insulin requirement comes down very significantly. We need to be monitoring their GRBS as well post-pregnancy. So we call them after 6 weeks for OGTT. If that is normal, every year we should be monitoring them because the lifetime risk of having a type 2 diabetes in someone who has had gestational diabetes is 50 to 60%. That's a huge, huge risk.